Okay, let's get started with our perfusion types of shock part 2. During this part of the presentation, we're going to talk about distributive shock. There are 3 different types of distributive shock that we're going to discuss, and that's neurogenic shock, anaphylactic shock, and septic shock. I'll go into each one of these shocks in a little more detail with the other slides, but neurogenic shock has to do with the spinal cord. Anaphylaxis has to do with a sensitivity reaction, and septic shock has to do with an overwhelming systemic infection. Some of the causes or contributing factors to neurogenic shock are spinal cord injury and spinal anesthesia. Anaphylactic shock is an allergic reaction, could be to an antibiotic, a transfusion reaction, a bee sting, or any allergen, including food allergens. One of the most common food allergens that causes an anaphylactic shock reaction is peanuts. Septic shock, some of the causes or contributing factors to it are immunosuppression, chronic illnesses, and malnutrition. Invasive procedures also a risk factor for these types of shock. Let's look at the difference between distributive shock and hypovolemic shock or cardiogenic shock, with hypovolemic shock being a volume issue and cardiogenic shock being pump failure. Now we're looking at distributive shock. And distributive shock is a shock that you actually have adequate fluid volume, but what happens is when the body is invaded by a causative factor with neurogenic, septic shock, or anaphylactic shock, you get a profound vasodilatation. This profound vasodilatation then creates a relative hypovolemic state because of that vasodilatation. So the kinds of things that we're going to see is this vasodilatation causing that relative hypovolemia and a reduction in the systemic vascular resistance or a reduction in the blood pressure, as I talked about earlier when I talked about relative hypovolemia. These changes lead to a reduction in the blood pressure and a reduction in organ perfusion. Another thing that contributes to fluid issues and volume issues in distributive shock is that we get a capillary leak syndrome that worsens the hypovolemia and causes edema. This edema can be anywhere. It can be pulmonary edema, it can be peripheral edema. So those are the kinds of things that we look for in this distributive shock. All right, let's look at one distributive type of shock, neurogenic shock. And what we're looking at with neurogenic shock is an injury to the spinal cord. And the injury to the spinal cord can come from several different things. It can be from an automobile accident. It can be from spinal anesthesia. It can be from a direct injury like a gunshot wound to the spine. But what happens is whenever we injure the spine, then that disrupts the autonomic pathways in the spinal cord. These autonomic pathways will then, usually our sympathetic nervous system, which takes over influence of things like heart rate and blood pressure, it will be disrupted. And the influence of that sympathetic nervous system will be reduced. And the parasympathetic nervous system takes over. With that parasympathetic nervous system taking over, then what we're going to see is a slowed heart rate lots of times and decrease in blood pressure. The other thing that happens is vasodilatation, as we talked about in distributive shocks. That vasodilatation is then going to show up as their skin is going to be warm and dry, and we're going to see bradycardia. That's why you're going to see neurogenic shock called warm and slow instead of cool and fast. And the warm and slow, warm relates to the skin and slow relates to the heartbeat. And cool and fast, as in hypovolemic shock, relates to the skin being cool and the heart rate being fast. Let's begin to take a look at neurogenic shock. With neurogenic shock, it's often a result of some type of injury or trauma to the spinal cord. It results when your body loses function and stimulation of the sympathetic nervous system because of this injury or insult. Your sympathetic nervous system, maintains bodily functions during physical activity, and it includes your heartbeat, raising your blood pressure, opening your airways to improve breathing. Those are some of the kind of things that we look at for the sympathetic nervous system. If your sympathetic nervous system is not functioning well, then your blood pressure could drop. It can affect your brain tissues, your spinal cord, and your heart. So it can affect the heart rate. Some causes of neurogenic shock that we're looking at are automobile accidents that cause either central nervous system damage or a spinal cord injury, sports injuries causing trauma to the spine, gunshot wounds to the spine, medications that affect the autonomic nervous system could also be a cause, and improper administration of spinal anesthesia. So what happens with neurogenic shock? What happens with neurogenic shock after the insult to our spinal cord? We get vasodilatation, because vasodilatation is because we don't have that functioning of that central nervous system. So when we don't have that functioning of that central nervous system, the sympathetic part of the central nervous system, is affected. Then the parasympathetic part of the nervous system takes over, and then we get the vasodilatation. That vasodilatation causes that relative hypovolemia that we discussed earlier and causes that decrease in blood pressure. That decrease in blood pressure comes from decreased venous return to the heart, decreased preload, and decreased cardiac output. So that is how you get a decrease in blood pressure. The decrease in blood pressure then decreases perfusion. So the decreased tissue perfusion then will impair cellular metabolism. The cells are not able to extract the oxygen, nutrients, and glucose that it needs to be able to carry on metabolic processes, and we will have anaerobic metabolism. This is another diagram showing us what happens when we have a patient that is experiencing neurogenic shock. That stimulation of that parasympathetic nervous system, or inhibition of the sympathetic, whichever way you want to look at it, causes the vasodilatation, the decreased vascular tone, and decreased venous return to the heart, decrease in the blood pressure, and impairing cellular metabolism. Most of your spinal cord injuries are spinal cord injuries that will cause neurogenic shock are above T5. And symptoms of neurogenic shock consist of a low blood pressure and an excessive parasympathetic activity, which means that you're going to have a slow heart rate. So bradycardia is an indication of a neurogenic shock. The treatment for neurogenic shock, or management of neurogenic shock, is to restore that sympathetic tone. And to restore that sympathetic tone, we do have to stabilize the spinal cord. So stabilize the spinal cord injury. Sometimes this requires just positioning properly, but lots of times it requires surgical intervention to stabilize. And to the patient, we can let the spinal anesthesia wear off, but during the time that this is happening, we need to support the patient with fluid administration so that we can maintain the proper blood pressure, so that we can improve perfusion with these patients and keep the patient in proper alignment. The specific treatment depends on the specific cause of the neurogenic shock. Now, with neurogenic shock nursing management, as with all shocks, we want to try to treat early, recognize early, eliminate the cause if possible, administer fluids to be able to support the patient's perfusion, manage any kind of electrolyte imbalances that may have occurred, treat bradycardia if the patient is symptomatic, and then evaluate the effectiveness of our interventions. And hopefully, if our patient is bradycardic and has a low blood pressure, we will be able to make sure that we maintain adequate tissue perfusion. The last shock that we're going to talk about is anaphylactic shock. Now, anaphylactic shock comes from a severe allergic reaction. The patient usually already has antibodies to this foreign substance and develops a systemic antigen-antibody reaction. This can happen the first times that people are exposed, but it can definitely happen with repetitive exposures. So what are the signs and symptoms of anaphylaxis? We will see runny nose, swelling of the conjunctiva, central nervous system problems with loss of consciousness, confusion, headache, anxiety, swelling of the lips and tongue, swelling in the throat. This is one of the things that you want to look at from an anaphylaxis perspective. These patients, instead of it being a perfusion problem now because we have this swelling, we have an airway and breathing problem. This needs to be dealt with very quickly. Now, we also will have heart and vasculature issues. You can have a fast heart rate, you can have a slow heart rate. Lots of times we do have a fast heart rate with anaphylaxis, and a drop in their blood pressure. These patients will quickly become short of breath. They will have wheezing and stridor because of the narrowing airways. They may have a cough. They may have some pain or discomfort with swallowing. They may not be able to swallow, and you'll see drooling because they're not able to manage their secretions in their mouth. We can see skin hives. We can also see that they may have some abdominal issues with diarrhea or vomiting. But this extreme allergic reaction is a life-threatening situation and requires immediate action. And continuing on and looking at our anaphylactic reaction, airway, breathing, and circulation are big issues that we need to look at with these patients. It is an acute onset. It is life-threatening with the airway and breathing situation with our patients. And we need to call for help quickly. The position that you see in the picture on the right side of your screen is a shock position. I put it on a couple of different slides that you've seen throughout these presentations. Shock position is to have the patient supine and have the legs elevated. Now this is a child, so we're able to elevate the legs with our hand, but with an adult, typically we can put a pillow or put something under the patient's legs so that we can maintain the elevation of their legs. Whenever it's identified that a child is having an allergic reaction, we need to definitely eliminate, if we can, the allergen and get the child away from, get the child or the patient away from the allergen. And then we need to give them adrenaline or epinephrine. That is the treatment for anaphylaxis. We do want to establish an airway, make sure that this patient does have an airway, that they have high flow oxygen available. We do like to get an IV started and give them something IV. The other treatments that we can give these patients will come later, but the first treatment that you want to give them is the epinephrine. Most people that have allergies that cause allergic reactions as severe as anaphylaxis will have EpiPens. And these EpiPens can be used very quickly and hopefully start to reverse the process of this quickly as possible. When they're in the hospital environment, we are going to monitor pulse oximetry, blood pressure, and their EKG. Anaphylactic shock, as I talked about earlier, we want to remove that causative antigen. We want to give them medications to restore that vasomotor tone or that vasovascular tone, which is epinephrine. And then we could give them antihistamines. Benadryl is an antihistamine that may be given sometimes. We also have other antihistamines that you may see given to these patients. on a pretty regular basis. And we want to support their perfusion by giving them IV fluids if that's necessary to support their blood pressure. Anaphylactic shock is another condition where prevention is much better than the cure. So we would like to prevent our patients from having anaphylactic reactions. We want to make sure that we identify if they have allergies, medications, blood products, etc., and try to make sure that we avoid or set a plan of care so that there will be avoidance of any kind of allergies that the patient has. Educate the patient and the family of their risk, educate the patient and the family, and advise them to wear identification so that anytime this happens to them, the specific antigen or allergen can be identified quickly, or they can be identified as a person that does have allergies so they can be treated. Assure that the patient has the medication and knows how to use it. The medication we're talking about is epinephrine. They need to have an EpiPen. The EpiPen is very important for them to be able to have readily available. This is something that they keep on them at all times and need to have instructions so that they know how to use it and how important it is to use it quickly. If the person is going to have to self-administer the epinephrine, it has to be done quickly before they lose consciousness. Now let's take a look at septic shock. Septic shock, last but definitely not least of the shocks, with septic shock being probably the highest mortality rate of any of the shocks that we have. And the most patients that we see in the hospital, we see septic shock and hypovolemic shock the most of any of the shocks that we've talked about. So when we're talking about septic shock, we're talking about a patient that comes into the hospital, as we talked about sepsis a few weeks ago. My recommendation is to go back and review your notes and review your PowerPoint on sepsis. And with sepsis, we talked about the patient, how they would have 2 of SIRS criteria, plus they had a suspected or were diagnosed as an infection. So that would be defined as sepsis. This patient, if sepsis does not is not treated effectively, then they can develop severe sepsis. And now we're talking about septic shock. With septic shock, we're talking about the bacterial endotoxins, as you see on this diagram here, cause a widespread leukocyte activation or an increase in their red blood, in their white blood cells. Their white blood cell count is elevated. Because of that, the bacterial endotoxins and that reaction by the body to try to fight off this bacteria, we get a massive release of cytokines. Those cytokines cause a multitude of things to happen. And you'll see some of the things that happen in that cytokine release response. I'm not going to talk about every one of them, but we do get a febrile response. We get an increase in the body's metabolic rate. We get vasodilation. So the vasodilation, that's why septic shock is considered to be a distributive shock, because we have the vasodilation that causes that drop in blood pressure. And we get increased capillary permeability. That increased capillary permeability, then we have loss of fluid from the cells, and that can result in cellular death itself. We get impaired cardiac contractility due to the decrease in oxygenation and perfusion to the cardiac muscle itself. Renal function can be affected, and we get poor hepatic synthetic function as well. And that hepatic function, or the function of the liver, is what leads to coagulopathies. And those coagulopathies can develop and progress into DIC, as we talked about the other day. Let's go back to the vasodilation in the middle of this diagram. The vasodilation will lead to hemodynamic collapse. That hemodynamic collapse results in decreased blood pressures, decreased MAPs below 60, and when somebody has, there's kind of an overlapping in severe sepsis and some of the initial phases of shock, so sometimes it gets a little bit confusing. So try to just think about it when we're talking about shock is the initial, those phases of shock, the initial phase, non-progressive, progressive, and then refractory phase of shock. So once the patient is vasodilated and they're not treated effectively, they do get hemodynamic collapse. That collapse leads to the shock. It also leads to a respiratory failure and to some other kidney dysfunction and dysfunctioning of the liver. Now, when we were talking about sepsis a couple of weeks ago, we went into a lot of detail about what happens with those bacterial endotoxins and how that causes the vasodilatation, the coagulopathies, and decreased perfusion to the organs, and how that decreased perfusion to the organs leads to organ dysfunction. So now, instead of going over that again, we're going to talk about what are we going to do about it. What we really need to do about it is, especially in septic shock, we need to identify things early. Just like we talked about with sepsis, we need to identify that a patient is septic. We need to treat that patient with antibiotics and fluids, get the blood cultures, make sure that that patient doesn't progress to severe sepsis or then to septic shock. With that being said, we do have some patients that do progress to septic shock. So once the patient progresses to septic shock, we need to make sure at that point that we know the identifying problem, that it is an overwhelming infection, and we try to eliminate the cause of the infection. Bacterial, fungal, whatever the cause of the infection, we need to have the patient on broad spectrum antibiotics, maybe an antifungal, whatever else we need to do to identify and eliminate that infection. We also need aggressive fluid resuscitation. This is a patient that we're going to continue fluid resuscitation until we get an adequate map. And how do we know we have an adequate map? We look at our patient's tissue perfusion as well as looking at the map itself. Another good indicator of adequate fluid resuscitation is your CVP. These patients are going to be in the ICU. They are going to have a central venous line, so you can monitor their CVP. So we want to see that CVP within normal range and maybe a little bit higher than that, bottom scale of it, because we know we have vasodilatation going on. The other thing that we will do with these patients is once that we get adequate fluid resuscitation, we can, if their blood pressure is still low, we can initiate some vasopressor therapy. The different drugs that you might see used are norepinephrine, or Levophed is the other word for that one. It's a vasoconstrictor, or vasopressin. Vasopressin being another vasoconstrictor that we can use. But we don't usually use the vasopressors until we have aggressively fluid resuscitated these patients. And I can't stress that point enough. You have to have the tank full before you can squeeze it. If we don't have adequate fluid resuscitation and we're squeezing an empty tank, it's like squeezing an empty balloon and trying to get air out of it. But if we want to get air out of the balloon, we've got to blow the balloon up before we squeeze it. And that's what we have to do to treat septic shock in these patients. Because of that massive vasodilation, we have got to fill that bigger tank up with the fluid, and then the vasopressors then will help squeeze it to improve the mean arterial pressure. Other things that we need to think about with the patient in shock is we need to think about aggressive nutritional supplementation. Patients need adequate amounts of glucose to be able to carry out metabolic processes. This is an increased metabolic state. So we would be looking at some type of nutritional supplementation. Sometimes these patients cannot tolerate enteral supplementation. They can tolerate parenteral, which would be total parenteral nutrition, or TPN is what we would look at. There's some interesting studies out there now that show that there is not much of a difference in outcome whether we use enteral or um, parenteral nutrition. The improvement with outcomes is that we maintain the patient's nutritional status. The other thing that we need to do with these patients is with glucose management. Glucose management, the increased glucose levels because the stimulation of the cortisol and increase in this stress response that the body is having, as well as we need to have insulin available so the cells that need insulin to uptake the glucose can use that to uptake the glucose that they need to be able to carry out metabolic processes. So going over it quickly with septic shock, we're going to give them the antibiotics. And yes, we do try to do the blood cultures before we give antibiotics. We are going to do aggressive fluid resuscitation, and we are going to try to maintain them nutritionally as well as glucose management. After we have aggressively fluid resuscitated these patients, we may have to bring some vasopressors on board, norepinephrine or vasopressin, to be able to support or improve the patient's perfusion and increase their MAP. One of the things that you want to remember about these patients that we start vasopressors on is that these drugs are terrible on the patient's veins. And so if you have a patient that has a CVP line or some other type of line besides a peripheral IV, it is really important to put these drugs in that more reliable line. They are vesicants, so if you were to put them in a peripheral IV, they're not going to last very long. They're going to tear that vein up, and that vein is going to become phlebitic, and you're going to need to take that out. So these caustic vesicants need to go in some type of central infusion for these patients, as well as they are what we consider to be life-supporting medications. And when we're looking at medicated drips with our patient, we need to look at lines that are going to be dependable because this patient's life depends on that medication. Okay, one more thing with septic shock is our nursing assessment and nursing management of this patient. We're definitely going to assess it. We need to identify the risk factors. Early detection is a key with our patients that are septic. Intervene early, intervene aggressively. Monitor for changes in oxygenation, cardiac output, lactate levels. It's imperative that we monitor lactate levels on all of our patients in shock and manage their glucose levels. Evaluate often for improvement or progression of sepsis. That is a key evaluation that you want to look at. The last couple of slides I have are just taking a look overall at shock again, and we're going to talk about it a little bit. One of the things that I want to try to use this slide to look at is to look at that all shocks go through the different stages of shock. I don't have all the stages of shock on here. I do have the initial stage of shock and the initial insult for several of the stages of shock that we talked about today, not anaphylaxis. But if you look at this slide, you start at the top with the normal oxygen delivery system, blood volume, the heart, perfusion, and we send blood to vital and non-vital organs. And you can see non-vital organs still don't get as proportionate a share as vital organs do because they utilize more nutrients and oxygen for the metabolic processes. With each type of shock, there's a different portion of the oxygen delivery system affected. So when we look at hypovolemia, the problem is blood volume, and you'll see how that affects the oxygen delivery system. When we look at cardiogenic, we have plenty of blood volume, but we have a pump problem. So because of this pump problem, we have decreased cardiac output, decreased blood pressure. So that is the problem with oxygen delivery during cardiogenic shock. When we see septic shock, then we have that massive vasodilation. That massive vasodilation is systemic, we had an adequate blood volume. The pump is not a problem for us now, but we have that vasodilation, and that vasodilation will cause an increase in heart rate and a decrease in blood pressure. This says that you'll have an increase in cardiac output. You have an increase in cardiac output early before the overwhelming massive vasodilation that we see. So you'll see a comparison in these three types of shock, and with these three types of shock that we've talked about today. So I hope that that helps you see that each type of shock does go through the different stages of shock, and there are different reasons that we have the oxygen delivery problem to the cells. Slide just gives us another comparison. It gives us a comparison of hypovolemia, cardiogenic shock, and anaphylaxis and septic shock. And what happens is we go through and we look at what's happening with them, the different symptoms that they have, with the end result being of all of these shocks, hypoperfusion to the tissues and cell anoxia. So the cells don't get the oxygen that they need. That resulting shock then will result in kidney failure, lungs, gastrointestinal failure, lesions, ulcers, and also other types of organ failure. We talked about liver failure as well when we talked about shock. And all of this will lead to death, and death is usually related to a cardiorespiratory failure. Again, here we have that death spiral of shock. This is just to re-emphasize that early recognition, early intervention, recognizing what the cause of shock is and how to treat that cause is our patient's best chance of surviving shock. Because this shock is going to cause that tissue hypoperfusion that leads to myocardial dysfunction, releases vasodilators, worsens the systemic inflammatory response, and causes more vasodilation as well as third spacing of fluids, and that just perpetuates the shock. The myocardial dysfunction in all the stages of shock perpetuates the perfusion issue, and in all the different types of shock. All right, I believe that's the end of this presentation.